One of the most mysterious parts of child infections is that the rash often comes later and they're not really that contagious anymore, so it's sort of a bummer. So often you get that high fever and there's no symptoms, and you're like, what's going on here? Well, that's clearly a virus getting started. And then by the time the child erupts in the rash, the illness is abating. So it's that was always our we think in the office we a child was experiencing Fifth's disease, the slap cheek parvovirus, or that maybe they had a roseola from the fever, but we wouldn't know for sure until 3 days later if the parent confirmed by calling back, oh, sure, yeah, then the big full body rash emerged. So I think Oakley's saying now that winter's here, what to do if a child has a white blotch surrounded by red on cheeks after being outside in the snow. Okay, interesting. Well, I would want to know more about the length of the exposure and what the temperature outside was, because frostbite itself is rare for the amount of time that young kids hang out outside. And the true frostbite exposure is, like, we can also look this up in healthychildren.org, is a prolonged exposure at a very cold temperature. So if you're seeing a white blotch surrounded by red, that sounds more like a cold reaction, which isn't as concerning as frostbite, but you'd still want to just warm up that skin. And there is some evidence that we should, try to warm slowly to let the skin reperfuse, it's called, like to bring back the blood flow to that white area. So there's no reason to put like a hot pack on it. You would want just to come inside and let the indoor temperature bring back the blood flow. Hope that helps.
And then I am putting a frostbite and hypothermia cold weather safety for children from healthychildren.org in the chat as
Thank
well.
you. A follow-up question about preventing frostbite. I actually don't know the answer to that. I guess I would just be practical that we don't need to put salve on our face. We just need to not be outside in freezing cold temperatures for without cover for too long. You know what I'm saying? Like, it's not clear to me that a salve would prevent that, but a face, a scarf would. But when we get to Tom's presentation, I can take a little time to dive into Oakley's question and make sure we get an answer by the end of the hour. I do love that you're outside with kids, though. Don't be afraid of the cold. I think we are hardy and frostbite's rare.
Our next question is, we're looking for guidance on return to school plans for different illnesses for young children and how that return to work plan may differ for staff who are less likely to drool on their friends.
First of all, hardest question that gets asked of us almost every webinar because of what you taught me during COVID. So I just want to repeat how every time I see your names, I get that feeling of your courage and what your day to day is like. It was really intense during COVID, and it's still really hard. The whole return, there's very clear guidance about illness. If a kid's gone 24 hours without a fever and his symptoms are improving, he comes back to school. Childcare, school, all things. But the problem with your settings is that we're asking a lot of young people. They come back and they have to participate in your program. And if they can't participate because they're too tired, they're still recovering, they're lying about, they're not able to dress themselves to go outside, and they're drooling all over people, that has to be a conversation between you and the parent to say, I just made, I know you got to get this kid back here, but he's not well enough to be here today. And that's subjective, right? It's not as easy as here's a piece of paper, please don't come back until your child can run around for 4 hours without taking a nap. So the resolution of fever and the starting to feel better is all we can really offer you in the official capacity. The drooling thing is of great interest to me because I think just the way kids handle their secretions in general is so variable that, again, you're going to have to make a judgment call based on your own experience. Because some kids are covered in, um, their noses run the whole winter. And then some kids are just droolers anyway. And then there's a whole bunch of oral kids, as you know, who are just constantly in and out of their mouths. So that whole milieu of just fluid, and you can't really attribute it that that's like going to spread the disease that the kid just recovered from, but it's just going to be disease spread in general. And I think you recall Becca, who had just joined. Hi, Becca. Becca had some great data for you guys last winter, or some study. I mean, the amount of infections that toddlers and kids in your care get in a given winter is just like one, two, three, four, five, I forget what it was, but it's like 10 or 15 or so here we go. It's December and you're just going to be hand washing and wiping and hand washing and wiping and trying to figure out who can participate in your program. So that's the long answer to the how to, and then, the faculty or your staff and your team is the same, right? 24 hours fever free and feeling better. Come on back. And they just do a little bit better with their secretions. Do you guys like that word secretion? It's like the word moist. It's so, ugh. Hi, Beck. Thanks for coming. We're just
Hi,
rattling
everyone.
through. Yeah, yeah.
Good to see everyone.
Okay, our next question is also for Breena. Does teething result in a fever greater than 100.4? How long should, so maybe we'll start with that one. This seems like a little
Yeah.
bit of a two-parter.
Yeah, that's the answer is no. I mean, there's a lot of people that associate they think their kids get hotter and their temperature goes up from their teeth erupting, but there's no biologic medical reason that would occur. It feels true, and unrelated to me, but it's also, something to monitor. I think if kids have a true fever over 100.4, that there's something else going on. Now, can you teeth and also experience a rhinovirus and a respiratory virus? Sure. Especially for the reasons we just described, that, the average kid gets so many low-grade viral infections in a year. So, Beck, do you have anything more to say about that? It's a wives' tale, or what, it's a myth.
Yeah, I would just say that like teething happens around the time when kids get a lot of illnesses. So I think people have made that connection in their mind. Yeah. And like it does cause them to be fussy. So Um, that's true,
Yeah.
but I wouldn't attribute a fever or a true fever to teething. And again, it may be that there's nothing really much different, to do, but I think just the idea of saying like, oh, no, this is just teething. It's not really just the kids are teething around the time where they're getting a true respiratory virus every 4 weeks. It's the same. It's that Venn diagram is like just a circle. So.
Yeah.
Okay, and then our second part of the question is how long should a child be out of childcare if they have hand, foot, and mouth, strep, flu, COVID, thrush, pneumonia, RSV, and Pedigo?
Yeah, that Becca can enhance my answer. It's the same as what we were just talking about. So it's the resolution of fever and the feeling better and on the upswing and able to participate in your program, regardless of what caused the illness to start or why they were out of your center or your home. No special criteria anymore about COVID, which has taken all of us a really long time to settle into. It's the same as if they had strep, pneumonia, otherwise. But the real topic here is the pressure on you to welcome kids back when they still don't feel well enough to participate. And that pressure is not going to go away in the society until we support people to miss work to be home with their children when they're not well. So it puts you in, and we all have stories and of our own children and things we did with Advil, and I can tell them now because my kids are in their late 20s. But, how do I get this kid back to the program? Advil, right? And I'm sure you see that in your day, that if that's occurred at breakfast, then by nap time or midday, your kids are fading that needed to be home. So I
Yeah,
may fix that in my lifetime, Becca. I don't know why we don't value the care of children, but we sure don't on many fronts.
nope, definitely not. Yeah. Yeah, I would say to simplify things, yeah, it really is just when the fever is gone and the vomiting's gone and they feel well enough to participate. And that caveat, it could be different for different things, right? Some people might have a specific diagnosis but feel better really quickly, and others may not. There might be caveats. I'm just saying this because we're seeing a little bit of this in Vermont, where the health department would work with you about very specific things, and those would be pertussis, which unfortunately we're seeing some pertussis, which is whooping cough, and and measles might be another thing, which where but that would be something that the health department, the folks on this call, would actually help you with what you need to do around those cases. Those are like reportable cases, but everything else is just going to be when they're feeling better. I will also add, in case we don't have time to talk about it at some point, flu season has not started. Sorry, I know people are like, oh, there's been a lot of colds going on. It's all rhinovirus. We're seeing a ton of rhinovirus like we do every fall. Flu has not started and RSV has not started. So if you
Yep.
recall, we had that early season a couple years ago with RSV in Vermont. It's like flu will start in December. It peaks in January. We still have it in February, a little bit in March. We get that flu B secondary thing. And then RSV, oftentimes before COVID, it would peak actually in Vermont in March. So I'll also say, on the one hand, we actually are not at all in the thick of it yet. On the other hand, it's absolutely not too late to get the flu vaccine. I'm getting my kids their flu vaccine tomorrow. They have their well child check. So absolutely be like, it hasn't even started yet. Like, get your flu vaccine. And then the RSV antibody shot was a game changer last season. It's for all children under the age of 8 months. And so you might have those folks in your at your that you care for. You also might have like sibling, like if it's a newborn, you've got like a 2-year old and then the newborn 2-month old at home and they haven't started yet, but like let those families know that it made a big difference. So those things, there's something to do about it, but I just also want to just steel yourself because we're not seeing any of it. We're doing all the testing, right? And so we know when flu starts and when RSV starts. And once it starts, it's like 12 weeks of like tough stretch. So, but we can
Yep.
do something
Thanks,
about it.
Beck.
Vaccines, yeah.
And folks, the people that have experienced pertussis in Vermont to date have been unvaccinated or what we call under-vaccinated, maybe got a few doses and then not. So it's a great reminder of what we're trying to prevent here and the fact that it is 100% preventable. So if you have opportunity for those conversations, we did also just hear from the health commissioner that COVID and flu vaccine rates they're lower than previous years in December's. And, we're going to spend some time maybe in our January call with you, just talking about what's happening in this world with the government changing the long-standing scientific approach to protecting children, protecting all of us from vaccine preventable disease. So I hope that's not why the rates are lower than they were last year for vaccine, but the more people that get vaccinated, the better we all do. So, little important reminder.
I dropped some links in the chat from the health department, our resources on whooping cough, measles, and our updated flu, COVID, and RSV vaccine page. We revamped all of these pages to be easier for folks to navigate. So I would highly recommend checking that flu, COVID, and RSV page out if you're interested. And as a reminder, all these answers and links will be sent out with the post meeting materials. So don't feel any need to try to save all of those. They'll be sent to you. We do have a question in the chat. In your pediatric office experience, what are your preferred by communication strategies, communication workflow between childcare director and medical provider for diagnosis, treatment, exclusion, and readmittance to childcare? How have you communicated with the childcare director when close contact prophylaxis is recommended?
Yeah, that's a great question. That's actually from Valerie, our awesome public health nurse in Morrisville. So the best practice here would be that there be an identified contact in a medical home, in a medical practice whose job was to communicate with childcare and schools. And we set that model up pretty strongly to, but it often could be the triage nurse. So I think sometimes it's someone different. There are care coordinators and other staff, but when you have a triage nurse, that person is protected in the day to talk on the phone, not to room patients or see patients. So I would like the health department to call the triage nurse at the practice, and then they would set up the communication to the child care director. But what we can really do with this call real time as we move into the next few questions, which are pretty complex, is hear from you all what's worked. I think we know what doesn't work, which is not speaking to each other, which is what, unfortunately, my observation on the earth is when people get busy and stressed out, they stop collaborating and they stop communicating. So I'm sure you have a lot of those stories, but if anybody has a bright spot of, oh yeah, this is how we do this in our community, I'd love to hear it. And Valerie, go ahead. You got your hand up.
Yeah, I mean, first of all, is having that consent form, right? So having, oops, there I am. Having the consent form to speak. So making sure that that is faxed over to the provider office. So that's step number one. And then, could there be a form perhaps that goes home with the parent that can then go to the child care director? That's something we're tossing around in our community. Um, Having the directors know sort of what the standard protocol, standard orders are for some frequent things. Because I think that the challenge comes in is when, and this happens for school nurses as well, in terms of getting that, because the directors are not only wanting to protect the child and the other children, but also their staff, in terms
Of course, yeah.
of spreading whatever it happens to be. So, I've been poking around and looking for some documents, if you will. Their DCF has something that's rather old, but it could work. Um, so yeah, I like the idea of sort of setting up that contact person. So encouraging that. The triage nurse being and just making sure that the HIPAA form is in the record.
Yeah, that's great.
Okay, our next question is for Becca. What are the illnesses that parents should notify me that their child has? And what illnesses should I notify families in my program about? As an independent program, we do not have a school nurse. Is there someone I can reach out to if I have questions?
Okay, let me start with the first part, and then I'll have Breena do the last part, which is
Yeah,
about communication as well too, because and we just recognize like it is so wild for you all to have to be like, right, you don't have a school nurse, and so this is like really super challenging, and you should feel supported, and so that's really the takeaway here, but and also Breena might need to correct me on this, but really, again, we've got those like rare, but like health department related reportable diseases that I mentioned, like pertussis and measles. And that's something that the health department will work with the family and you about. There may be um, a few other like health department reported conditions. I had one recently where the child wasn't in childcare, but if they had been, that would have, that would have been a reportable thing. The health department would really contact you for that. Um, I'm not sure how helpful the like, I know some places will say something like, hand, foot, mouth is going around, or strep is going around, or RSV is going around. And I would say from my end as like both as a parent, but also as a medical provider, I'm not sure those notifications are really necessarily helpful. And they're certainly not like required at all. We know when it's RSV season. And I think it sort of doesn't change what you do. And I don't know if how parents react to that, if it makes them sort of more worried. It sometimes leads to then parents wanting to get their kids tested. And it's really, a clinical decision around that. So I actually can't really think of anything besides the health department, like
Yep.
reportable disease type thing, that really parents need to tell you about, or you need to make an announcement about, because it's all kind of, it's all kind of stuff that pediatricians and parents, they could be getting it anywhere, not just a childcare. It's like RSV season. We know RSV is going around. We don't really have to announce it. So that would be my take on that, but I'll turn it over to Breena.
I agree. I agree with that, Becca. So I would call your district health office. If you are noticing a trend and it's not a reportable disease, which is in statute that we gave you that list, it's long, but it's not the routine things in childhood. It's other stuff. But COVID's on there still. If you're noticing like, oh gosh, that's like the fifth kid with hand, foot, and mouth, you can call and talk it over with your family and child health coordinator nurse at the district office just to wonder. But I agree with everything Becca said. I always was so curious, and this is a human psychology thing. I don't know why we like to know something's going around when our kid has it. It's like, I guess maybe it makes us feel like it was just completely like not preventable. Like, oh, well, it was going around. But maybe it heightens people's observation of their child's symptoms and that normally you wouldn't notice. But if there's hand, foot, and mouth, maybe the pimples on the kid, the pustules on the kid's hands is noticeable. I'm not sure. But I like the way Becca described it. I think everything's going around all the time. I mean, I think there are certain seasonal things, but once we get into a season, it's not, we don't have to say now just this center has RSV because every childcare environment has someone with RSV, or not yet, but soon. So I hope that's helpful. A lot of half answers for you guys today, or yes and answers, I guess.
Next question is for Becca. Will infants and toddlers be eligible for the COVID vaccine? Are there any changes to immunization schedules based on RFK's recommendations? And just as an aside, before I pass this over to Becca, we are planning on having the Vermont Department of Health immunization team come and talk to us a little bit more in depth about the changes to immunization schedules and RFK's recommendations and the health department's stance on all of that in January. So we'll dive a little deeper into that next month.
Yeah, the short answer is yes, it's still available, and no any changes. And just kind of like as a big picture statement, just to kind of wrap your head around like a lot of the details that we hear or headlines that we see. A lot of the discussions that are happening, whether it's about COVID vaccine or other things, really in practice turn out to be not a lot of difference. So there was like a lot of discussion about COVID vaccine in kids at the federal level, like coming sort of from RFK Jr. And then like really and if you listen to the headlines, you're sort of like, oh, it sounds like they're not really recommending it anymore for kids. But then when you actually get the fine print, or we get the information from the actual like CDC, oftentimes just like, yeah, the COVID vaccine should be recommended, or could be recommended, and there's specific population, including children who've never received the vaccine before, which is going to be a lot of your um a lot of the kids that you work with. And so it's really like meant to confuse people. But and there was a lot of confusion around like, are we going to be able to get it? Is insurance going to pay for it? All of that stuff. And that in Vermont has really been sorted out. And so for flu, like always, any child over 6 months of age should get the flu vaccine, and that is available now, and kids should really get it now. Um, for COVID, same thing. It is for kids over 6 months of age each year. There isn't like a COVID season really yet. Maybe someday there will be, but there isn't really yet. And so we're not going to families now. I mean, I think for most families, they're going to get their flu vaccine, they just get the COVID with it. That's like easier. But if for some reason that's not, and they really are like, just I want what's the more important one to get right now? It's flu. Like flu is around the corner. So and then the RSV shot is from birth, if they're born in RSV season through so it can be newborns and then up to everyone who's 8 months of age. And then there are some kids that also qualify for it. So I think part of what's happening is that there's so much confusion about it that parents are like, is insurance going to cover this? Can I even get it? I'm not even going to look into it, which is sort of the point. But no, those are all available. And the places that you would be getting those are going to be at your child's doctor's office is the place where you get it.
Yeah, and I'll just add that with all the confusion and sound bites and news, I think it really brings me back to the relationship that your children have, you and parents and children have with their medical providers. Because the conversations can occur there, and we're working with our pediatric and child health professionals about just what do they need to make sure they can give accurate information to all the families that are coming in with confusion. So, I mean, you as daily, trusted advisors to families can say what Becca just said, and then also that it's really great to talk it over with your doctor because it's hard to know what patients hear and what they're worried about. There's about 10 different ways to talk about this, 15, 20. But I will say just from life, the American Academy of Pediatrics, which is a neutral professional organization with 67,000 pediatricians, has the vaccine schedule now separate from government. Because what's going on in government is hard to follow. So I put it in the chat, but you have our endorsement of the American Academy of Pediatrics because they're scientists and we know them, and they're working very hard to keep kids safe.
Our next question is for Breena. If a high school child has 4 DTaP and 1 Tdap, are they compliant for school?
Okay, so first of all, so happy to have a high school question. Completely threw me off. But maybe, Julia and I discussed this. We thought maybe there are high school kids caring for children in some settings, which is great, and that wondering if they're protected. I can't really answer this question without knowing when the child had the vaccine. So you need 5 versions. You need 5 Tdap, sorry, 5 DTaP. But if you don't get 5 and you show up at some point in over the age of 4, then you can get away with 4. If I'm sorry, with if you haven't had 4 by 4, then you can get your fourth after 4, and then you don't need a fifth. But you see, the reason we don't want to do this verbally or just try to create some quick answer to a complex question is the immunization schedule is very clear, and I put it in the chat, and it tells you how this rolls, but you have to know when the vaccines were given to those individuals because our immune systems handle vaccines differently when we're young than when we're a little bit older in a good way. It's like this memory, and these boosters are all about getting us to higher levels of protection. It doesn't mean you don't have any protection unless you have all of them. It's like this staging of reminding the immune system what the goal here is. So it's hard to answer in a vacuum, but the general, if you follow the immunization schedule and you get vaccines on time, you get 5 Tdap before you would, and then you get a booster at 11. That's when it switches to the Tdap. And that's way too scientific for this conversation of why we go from the big D to the little d. But it is all dependent on when you get them. So, and this is what's so hard about your role because you don't have a medical person to readily kind of bat this through. So if that is the case, that it's one of your provider, that you have a teacher in a classroom that you're trying to figure out that really needs to be discussed on a case by case basis with their medical provider to make sure they're covered. I've never liked the idea that non-medical people should be like looking at the chart and figuring out if it's covered. And then there's a whole other thing if you're a new American or if you come if you don't get vaccinated for various reasons and then you start, that schedule is a little bit different and also important to interpret through the lens of a medical person. Make sure, is this person really covered? So, long answer.
Our next question for Breena, what can we do on the early childhood education end to increase partnership with pediatricians? We'd love to invite them to chat with our preschoolers or have families or have informational handouts to share.
Yeah, so this is kind of our, I mean, it is not blowing smoke for me to say, I just want you to reach out to me and I will find you. I need to know where you are and we will find you those pediatric connections as well as your district office. We have several on today. The family and child health coordinators want to help you with this too, because several of your questions this month were about child development and autism and this recognition that kids are being assessed in the community for autism and then that you're being handed, some of you wrote that you're in special education and early childhood and you feel there's like a pressure on the recommendation of what the child needs. And that is one of my biggest pet peeves in the intersection of healthcare and education. All healthcare providers are doing and should be doing is diagnosing. They should be doing whatever test they're doing. And I'll tell you a little bit about that in a second because we are doing autism assessment now in primary care because there wasn't enough developmental behavioral pediatrics. But once that person has had a comprehensive assessment and has a diagnosis, then it's up to you as the special educator to determine the treatment plan. And so if you get this ABA feeling from the provider, the medical person, that is annoying. And I know that's what a lot of people experience with special ed, that they're getting told what to do instead of what the diagnosis is. So, and that happens in older kids in, K through 12 as well. So what we're really encouraging here is everyone to slow down and figure out a way to get some team-based care here, which is to understand what just happened, which is that we tried to solve the long waiting list for children by building capacity in medical homes, primary care offices, to do standardized testing and assessing that actually does meet the criteria for, good medical practice. So what they're doing, it's the CARS too, if those are interested, and then something called STAT. It's not all medical homes. It's about 10 providers in the state. We train 17, and it's really taking the heat off of that waiting list. But if you're finding as the people in childcare or doing special ed that this is coming to you without that understanding, I really want to help you have a meeting. Because if parents are saying, "Hey, my doctor said my child has autism and you have to do ABA," and you're like, "Wait, hold on." Like that is my big I don't like that because that's a disruption to your field and your autonomy and it's a confusion of who's doing medicine and who's doing education. And the person that sent this question also referenced that it's even harder in new American populations, and I really felt for that. So, Julie, I just jumped to two questions, but what I'm really wanting to support, because we're such a small state, is just email me and your district. I'll get you in touch with the district office, and we can get these teams to come together to understand each other and to be in service of the same kids. Because I do, as said it 10 minutes ago, I'll say it again. I think when we're all stressed and moving quickly, communication breaks down first. Integration breaks down. Remembering our roles breaks down. Okay, I'll stop there.
Thank you, Breena. We did receive two questions that were asking different aspects of supporting children with autism, and I think that Breena touched on both of those. But if anyone here submitted those questions or anyone watching the recording who is reviewing the answer has any additional questions they want to ask Dr. Bell or Holmes, please reach out to me or them and we can get you some more in-depth answers or some more personalized things offline. Okay. And I believe that is all of our questions, which means that we are ready for our structured content section. Next up, we have Tom DeBell from the Vermont Department of Health, Division of Environmental Health, presenting on drought and unprecedented conditions that strain water supplies.
Yeah, thank you so much for having me. Really enjoyed hearing all the discussion and great questions, and I know this will be a little bit of a change of pace. I hope you appreciate the content. But yes, my name's Tom DeBell. I'm an environmental health engineer. I work in the Division of Environmental Health, largely in water treatment of private water systems. Here today really to talk about how the situation we've had with the drought in the summer into this fall has really affected drinking water supplies across the state, both public and private, and some of the impact that that's had on childcare certainly, but as homeowners, businesses, all across the state. So to start, I really wanted to mention this term that a lot of media coverage had, which is the term flash drought. Similar to flash flooding, it's not something that we're as familiar with. It really can intensify very rapidly, unlike a traditional drought that's usually caused just from a lack of precipitation. Flash droughts are really a perfect storm of a different combination of factors. So certainly a lack of rainfall is a big one, but abnormally high temperatures, low humidity, strong winds kind of make this perfect storm for really rapid drying of the land surface. A drought really of this severity and coverage of the state is really not in the records. So since records began for statewide drought monitoring, we've never seen something of this severity and something that came on so fast. Some of the kind of telltale signs that were more obvious were stream flows, lake levels dropping, and then certainly groundwater levels really diminishing super quickly within just a couple weeks. The graphic you see in the middle there is just a time lapse showing this kind of development and degradation of drought conditions starting first in July. So it really wasn't until July that we started to see this impact. And then by September, the conditions had intensified, like I said, to the worst drought severity that we've seen since the drought monitor began in 1999. Thankfully, in the month of November, the weather pattern has really helped alleviate a lot of the extreme drought conditions, but we are still several inches below normal. And with precipitation coming down like it is today in the form of snow, it's difficult to assess how much of that water is actually going to reach down and start replenishing water supplies. And this is the most recent map that was released last week. I think another one will be released today, really showing that despite the rain, despite the snow, the eastern part of the state still has a ways to go. And something that really makes Vermont especially vulnerable to droughts, unlike a lot of the states in the West that are a lot more accustomed to kind of drought conditions, is that such a large percentage of our population relies on private individual water supplies, kind of like the three that are shown here. Unlike municipal water supplies that really can consist of either reservoirs or sometimes several deep wells that collect water, these springs, dug wells, and drilled wells are all much more likely to run dry as groundwater levels drop. We usually think of these as serving just a single family home, which is the most common, but there's also a number of businesses, including childcare, some small schools, and food and lodging establishments that all rely on these similar supplies, meaning that, you know, one well running dry may mean two people without water. It may mean half a dozen people or more. Going left to right, drilled wells are generally the more resilient in times of drought, but they are significantly more expensive. So we do know there are a lot of these older hand-dug wells or bored wells. A lot of people do still source their water from spring systems, and those are much more susceptible to going dry. And just to distinguish a little bit what I mean when I say, you know, private water system versus public, I think in Vermont, sometimes there is kind of a gray area where there's some very small public water systems. Really, the distinguishing factor is how many people are sourcing water from it and how long. So in Vermont, a private water system is serving less than 25 people. And it's certainly less regulated. I think that's another form, is it's not unregulated. Um, there are cases where water quality testing is required in certain circumstances, like for child care licensing, food preparation, and wells drilled after 2019 require at least one-time testing. But it certainly is a contrast to public water systems where there's really a certified water operator, really regular testing going on, um, and really all of the protections of the EPA Clean Water Act have to be applied. And that's for systems over 25 people. They can range, from serving maybe 100 people to thousands of people, and they're all kind of covered in that public water umbrella. And I think that distinction is really important between private and public water because what was really clear during the drought is that disproportionately private water systems were affected much more. Since August, when we kind of stood up this system, there was 630 plus reports of water shortages or outages for people served on private water. The reports kind of peaked in October, which was again later than we would usually expect these things, but due to not receiving any rainfall in August, there is kind of a delay in when these things started popping up. In the last few weeks, we've thankfully been hearing more and more reports of people's water being restored, and hope to have a pretty detailed survey going out soon to really gauge what the recoveries looked like and when. One of the big things when we talk about like the number of reports, kind of going back to thinking on average each well that is consisting of 2 to 3 people, we've really estimated that at the peak of this, between 14 and 1,500 individuals faced water access issues, with the true number likely being much higher, knowing that not everyone's going to report a water shortage or outage to us. I think a really interesting breakdown when we were looking at those reports is that you saw that drilled wells were half as likely to run dry compared to spring. So there's definitely some thinking going on of making our water systems more robust, knowing that these droughts could continue on into the future. Another thing to mention is that while private systems were certainly affected much more, at the peak there were 19 public water systems reporting either conservation measures, outages, or concern about how long they were going to be able to supply water. We did a lot of work with our colleagues at the Department of Environmental Conservation to make sure water hauling was taking place. I know in some cases there was hospitals having to haul water in, so it was a pretty unique and unprecedented situation for us. At last check, I believe it was last week, we still know that 10 public water systems are still reporting some drought impacts all the way now into December. And the good news is, I think what we're seeing in the forecast looks really promising. We have seen a lot of recovery, but we're certainly not out of the woods yet. Thinking of the hydrologic drought, just how much water is still needed to get us out of this. We still need about 5 to 6 inches, depending where you are in the state, to get back to our normal water totals. Related to that is there's some good modeling out there to show what the probability would be that drought conditions have really resolve themselves, and that can be anywhere from, best case scenario is about 40% in the southern part of the state, as low as 13% for a lot of the state, especially in the Northeast Kingdom. We know we still need to get a lot of water there. Another concern certainly is with precipitation coming as snow, freezing happening, certainly some uncertainty in how much the precipitation we're getting now is actually going to reach and recharge groundwater. And as conditions improve, I did want to highlight some of the warning signs. I think this is something that's helpful for next time around. If we do experience more water outages late into the winter, these are some things to be looking out for. Telltale signs tend to be a drop in water pressure. It's not always a sign, but it is something to pay attention to. The next phase would certainly be in like sputtering of your faucets if there's air in your water line. The 2 images to the right are a little bit of an extreme example, but if you notice all of a sudden your water is dirty or cloudy, a lot of times that'll tell you something's going on in your well or your spring. And then really the last stages, especially if you're on private water, is if your pump circuit breaker starts to trip. That's usually an indication that it's run dry and it's turning off to protect itself. So those are some early signs. As that happens, it's good to start contingency planning where you're going to get water from. And I always like to do a plug. It's always, I'm asked often when's the best time to test your water. As soon as you can, usually is the right answer. One of the key messaging we're getting out as water systems are coming back online is that it's a great time, great idea to test your water, knowing that drought can change the water quality. And we've seen that in the data coming in. Our general recommendation is that private water systems for any use really should be tested every 5 years for common contaminants. I know it's a little bit different with licensing requirements, but that is something we try and shake out. And I also try to encourage folks that, just because your water is cloudy, it looks a certain way, a visual change in appearance doesn't necessarily mean the water is unsafe, but certainly is a good time to have it tested. I wanted to show just a little data that we've seen. This is data going back about 5 years now. That's all been compiled. But in any given year, we do see that about 45% of private water systems that are tested exceed at least one health standard, with the most common being bacteria. That's really kind of the driving factor is coliform and E. coli bacteria. But again, I wanted to show the difference too between those drilled wells, dug wells, and springs, how susceptible they are to different things. Drilled wells in particular, they tend to have a different concern, less with bacteria, more likely to have things like manganese or uranium compared to the shallower systems. So another consideration to keep in mind. And the big thing for child care is for anyone caring for young children, whether it's at home or at school or at child care, is contaminants definitely affect children more so than adults as they're developing. And oftentimes when we're talking about water safety, most of the contaminants that we're most concerned about don't have immediate symptoms. So bacteria, sometimes you can have things like GI upset, but if there's manganese or arsenic and uranium, those are really long things before you start to see symptoms. So it's really important to have those things tested and keep an eye on it regularly. And that brings me to some good news I do have to share. This was kind of recent that we got the okay that this funding will continue. But funding for testing of private water systems for licensed child cares is available through this form. Julia, I'll send you a copy of this presentation with PDF and clickable links so everyone has it. But certainly recommend doing that if you're either applying for a license or renewing a license. If you have questions about what to test for, I know lead testing is kind of a different approach. My colleague Jenna can definitely answer any of those questions. And as we kind of come to this, what a lot of our time has been spent is how do we prepare for the next drought to be more successful? And we do have a couple things. An upcoming guide will be coming out as an updated guidance of things to keep in mind for drought. But some of the things are really knowing who your key contacts are. Knowing who your town's local emergency management director is. That's a big part of the reporting structure of how we identify where issues are. Knowing who your water operator is. If you're on public water, they're definitely the rock stars that know the most about what's going on. If there's conservation things in place, they're the key contacts. And then we do have a great website for child cares and homes served by private water on what to look out for, conservation tips, and improvements that can be made to your well to make it more resilient to drought. And just closing off, as you have time, there's some great information here. I put a bunch of links in that I think would be relevant. Like I said, that updated guide to all things environmental health as it relates to child cares. I know a new PDF is being made and should be available in the next couple of weeks on this website. How to test your water. We get a lot of questions about what that process looks like. We have a step-by-step guide on our website there now. As well as like how to treat those things. I think that's always the second question is we find there is manganese in the water. How do we get rid of it? A lot of great resources there. And then of course, my colleague Jenna's information for any lead or licensing questions she can help answer as well. And then finally, if you're interested in more things drought, kind of keeping track as we move out of this through the winter, a lot of great resources on our website. There's a state drought website page, and one potential resource I was made aware of late last week is that due to the disaster declarations, there are small business administration loans. I think in every county but Grand Isle. So if you are looking to develop a drilled well from a spring that has gone dry, that's a potential funding source to look into as well. And certainly if there's any questions on these, definitely feel free to reach out to me. I'm happy to walk you through it. I know there's a lot of information in there. But if there's any questions I can answer now, I'm certainly happy to.
Thank you, Tom. That was great. And I will send out the presentation with the meeting notes, and I can also break apart some of those links and label them for folks for easy access, and those can go in the after meeting materials as well.
Perfect. Yeah, I'll send those to you right after this.
Yeah, and we will include Tom's email, so if anyone has any questions about the content covered in this presentation or other topics that he touched on at the end, please reach out. And if you connect with me, I can also route you to whoever you need to talk to over on the environmental health team. So with that, I just want to say thank you to Breena, Becca, and Tom for your expertise, and Adia for your support and technical assistance. And a very big thank you to everyone who came to the webinar today. Our next meeting is going to be next month on January 8th. In the meantime, please feel free to contact me with any health and safety questions or suggestions for future webinar topics. We really love hearing your input and questions. Thank you all.
Yeah, thanks everyone. Take care.